Hello, doctor. My name is David Menendez. My topic is Belatacept in long-term outcomes in kidney transplantations. Definitions. Belatacept-based immunosuppression as compared with cyclosporina associated with similar patterns and graft survival and significantly improved renal function in kidney transplant recipients.
The use of immunosuppressive therapies in patients with kidney transplants has reduced the incidence of allograft rejection. The current standard of care immunosuppressive therapy includes calcineurin inhibitors, such as cyclosporin, plus anti-proliferative drugs with or without maintenance glucocorticoids. However, calcineurin inhibitor-based regimens may not adequately preserve allograft function. In this 7-year extension of a previously published 3-year randomized trial, investigators compared the ability of belatacept and cyclosporin to preserve allograft survival and function. Belatacept is a fusion protein composed of the Fc fragment of human IgG1 linked to the extracellular domain of CTLA4. It blocks T-cell co-stimulation, thereby selectively inhibiting T-cell activation. 666 patients who had received a kidney transplant from a living or deceased donor were randomized to maintenance treatment including a cyclosporin-based regimen, a less intense belatacept-based regimen, or a more intense belatacept-based regimen as primary immunosuppression. All patients received basiliximab induction and mycophenolate mofetil and glucocorticoid adjunctive maintenance therapy. At the end of 7 years of follow-up, the belatacept regimens were more effective than the cyclosporin regimen. The estimated rates of death or allograft loss were about 22% in the cyclosporin group and about 13% in each of the belatacept groups. The estimated glomerular filtration rate was also higher with belatacept than with cyclosporin, suggesting that belatacept may be less nephrotoxic. The cumulative frequency of serious adverse events was similar across all 3 groups. Thus, treatment with belatacept as compared with cyclosporin reduced the risk of graft loss or death after kidney transplantation. Full study results are available at nejm.org.
Okay. Application in medicine. To randomly assign the kidney transplant recipients to more intense belatacept regimen or a cyclosporin regimen, efficacy and safety outcomes for all patients who underwent randomization and transplantation were analyzed at year 7.
Transplantation today provides our patients a remarkable benefit. They prolongs their lives, restores them to vitality and health. In the 1980s, the results of transplants were poor and kidneys were lost from rejection. And then we got the cyclosporin class of drugs, and they really revolutionized transplantation. Short-term outcomes got much better. We expected most of our patients to survive with a functioning graft for 90% of them at a year. The problem is that cyclosporin, while it's great for short-term outcomes, causes lots of side effects that really limit the long-term outcomes that our patients would like. Cyclosporin is very toxic to the kidney, and over time that can cause scarring and loss of function. And on average, our transplants only survive for about 8 to 10 years, which is clearly far short of what you'd like for our patients. In addition, cyclosporin causes lots of other side effects like diabetes. Perhaps a third of our patients will develop post-transplant diabetes. Almost all of them take blood pressure lowering medications, and most of them take medications to lower their cholesterol because cyclosporin causes all those side effects. So the patients will be on anti-rejection drugs, and then they'll take a handful of drugs to combat the side effects. and all of that leads to premature death from cardiovascular disease. So there's a tremendous need for better drugs to prevent rejection, but without causing all those side effects. The problem of rejection is that the immune system recognizes the transplant as foreign, and lymphocytes, T cells, attack and cause immune damage of the transplant. So we need drugs to dampen the immune system. Cyclosporin does that, and Belatacept does that as well. The problem with cyclosporin is it doesn't just affect the immune response. It also hits a target that's throughout the body. So all of those other targets throughout the body in the cardiovascular system cause those side effects of cyclosporin. Belatacept is different. It blocks the immune system, but it does so in a selective way, because the target of Belatacept is really only expressed in the immune system. So you can suppress the undesired immune response of rejection, but you won't see those off-target or the cardiovascular side effects. Belatacept has been studied extensively in kidney transplants, and those are the results that have just been presented. More than 1,400 patients have been studied in kidney transplant. Conceptually, this drug would also have advantages for other forms of organ transplantation, and studies are ongoing for liver transplant, and conceivably it could be a benefit for all the transplants: heart, lung, intestinal transplant.
The next video. Okay. Pros and cons. The mean estimated glomerular infiltration rate increases over the 7-year period with both Belatacept regimens, but declined with the cyclosporin regimen. The cumulative frequency of serious adverse events of month 84 were similar across treatment groups. Next video.
Welcome back to the Transplant Medications video. Belatacept is used to prevent rejection of your transplant. Belatacept is the generic name for Nulogix. You will be receiving it IV, which means it will be infused into your vein. Belatacept IV infusions will be given more frequently early after transplant and will eventually become a once-monthly infusion that you will receive lifelong. You will be given a schedule of your infusion appointments. It is important that you don't miss any scheduled appointments or move your infusion appointment to a different day. If you are having trouble getting to your infusion appointments, tell your transplant team immediately. Most people don't have side effects from this medication, but just like all of the anti-rejection medications, it can increase your chance of infection and cancer. This concludes the Belatacept video.
Okay. Appeared in Ecuador. A total of 116 participants were randomly assigned to a study group and underwent transplantation. Of the 667 patients who were treated, 153 of the 219 patients treated with the more intensive Belatacept regimen. 163 of the 226 treated with the cyclosporin regimen were followed for the full 84-month period. All able data were used in the analysis.
Sure, there are general criteria, and it'll vary by each individual transplant center. We don't have a particular weight restriction at our center. However, we do encourage any patient to be in the best physical condition they can going into transplant, and that would include their, being somewhere near their ideal body weight if possible. But for many people that's not possible, and we do transplant people that are obese. From a technical standpoint, actually doing the operation, it's a little more challenging, but it doesn't seem to affect their long-term outcome. They may have more complications related to their incisions, more infections, more hernias, but overall, their overall outcome tends to be as good as those who are of ideal body weight.
Okay. In conclusion, 7 years after transplantations, patents and graft survival were significantly higher with the Belatacept than with the cyclosporine. Thank you very much.